Okay, well, we are going to get started this evening. Hello, everyone, and welcome to the Melanoma Research Foundation's Ask the Expert series. My name is Miriam Kadosh, and I'm the Director of Patient Engagement and Education at the Melanoma Research Foundation. And we are very pleased to have you join us today for this special educational opportunity entitled 2025 ASCO Highlights for the Uveal Ocular Melanoma Community. Today, we are joined by Dr. Inderjit Mehmi, a leading medical oncologist specializing in melanoma. In this session, Dr. Mehmi will break down key takeaways from the 2025 ASCO annual meeting focused on the latest research, treatment advances, and clinical trial updates that matter most to the ocular melanoma community. Please stay with us until the end, as you'll have an opportunity to ask your questions live. But before we get started, I just want to share a little bit about the MRF. The Melanoma Research Foundation is the largest independent organization devoted to melanoma. Our mission is to eradicate melanoma by accelerating medical research while educating and advocating for the melanoma community. The MRF is committed to the support of medical research to develop effective treatments and eventually a cure for melanoma. A little bit about MRF's Cure OM initiative. Cure OM, the Community United for Research and Education of Ocular Melanoma, is the MRF's initiative to increase awareness, education, and research funding for ocular melanoma while improving the lives of people affected by this disease. Founded in 2011, the Cure-OM initiative excels because of the hard work and dedication of its patient and scientific committees and the generosity of our community. The Melanoma Research Foundation offers a wide range of free educational resources that I'll be sharing for patients, caregivers, families, and healthcare providers, including webinars like tonight's webinar, animated videos, printed materials, and events focused on melanoma and its rare subtypes. So each year we partner with top academic centers to host in-person symposia that feature expert speakers and opportunities for community connection. Our 4 recent events are available to watch online on our YouTube channel. And we're also planning 2 more for the fall, one in Santa Monica and one in Houston, Texas. So stay tuned for those fall dates. All of our education materials are free to download or to order for print and are available for use at health fairs, schools, conferences, physician offices, or for your own personal use. And we send them all across the country. We have 6 animated patient videos and 2 more currently in production, one for ocular melanoma metastatic disease. These are videos, they're less than 10 minutes long and packed with a lot of information with great visuals too. So if you have family or friends or you want to learn more about melanoma, these are great educational options to send around or to watch yourself. Here are 2 of our education materials that you can order or print on our website. We have a dedicated patient brochure and fact sheet for our OM community that you can see on this slide. We regularly distribute these all across the country, like I shared, for patient education and awareness. We are proud to offer 2 monthly virtual support groups for individuals with ocular melanoma, both primary and metastatic disease, and caregivers as well. These groups are designed to foster emotional support, shared understanding, and community connection. The first Wednesday of each month from 1 to 2 p.m. Eastern, 10 to 11 a.m. Pacific, group is held in partnership with the Sidney Kimmel Comprehensive Cancer Center at Jefferson and facilitated by oncology social worker Molly Vocino. And then the 4th Thursday of each month, 8 to 9:30 p.m. Eastern Standard Time and 5 to 6:30 p.m. Pacific Standard Time, is led by doctoral students in clinical psychology from the University of Denver. So please do join us for these groups that meet once a month virtually. To learn more or to receive Zoom details, contact us at curom@melanoma.org, and we will put that email address in the chat, but I will say it once more, curom@melanoma.org. You can sign up to receive our quarterly newsletter called Eye on OM. This is our newsletter specifically for the ocular melanoma community. It highlights community events, community members, upcoming support groups, new research, treatments, trials, and our advocacy efforts as well. Many of you might have heard about tonight's webinar from our OM newsletter that came out just a few weeks ago. So if you do not already receive our newsletter, you can scan the QR code on the screen to join us. We have a variety of patient and caregiver support services, so you can find these on our website if you're looking for more support or to connect with someone. We have our treatment center finder, our patient and community forum, financial assistance resources, our clinical trial finder, which I will talk about a little bit in our next slide, and our Ask a Nurse program, where you can email or call our nurse who can answer questions for you. So if you're looking for a clinical trial, and we will talk with Dr. Mehmi in just a moment more about clinical trials, we are proud to offer a clinical trial finder. It connects patients with trials tailored to their specific diagnosis, ensuring they receive the most up-to-date care options available. Patients can connect with a clinical trial navigator, gather information regarding their diagnosis, stage, and treatment history, provide information and contact details for the trial matches, and the navigator can help overcome barriers to enrollment, and then just basic education regarding clinical trials and the logistics of getting enrolled in a clinical trial. You can find this information on our website, melanoma.org, under the Patient Care tab. If you have any questions about your clinical trial, our clinical trial finder, or getting connected with a clinical trial navigator, please do let us know. We're happy to help connect you. Lastly, there are many opportunities to support the work that we do for the melanoma community through a variety of programs, events, and research funding. Feel free to contact us or anyone at the MRF after this webinar to talk to us about ways that you can engage in the melanoma community while investing in our shared mission. And the best way to learn about what we're doing in the melanoma space is to follow us on our social media channels. You can learn about our education efforts, advocacy, our research programs and our research funding, our awareness campaigns, and any upcoming events on our social media. That's the best way to keep tabs on everything that is going on. And here is our website. Visit us at melanoma.org to learn more. I'm going to do a little bit of housekeeping before I turn it over to Dr. Mehmi. We encourage you to use the Q&A box to ask questions throughout the session. We will get to those at the end. The information presented during today's session is for educational purposes only, and any individual treatment questions that you may have about your specific case should be directed to your healthcare provider. We encourage you to visit us at melanoma.org to learn more about the resources that I shared and that we have available. So at the end of the session tonight, a pop-up will come up on your screen for you to fill out a brief survey. Please do that so that we can hear from you and plan for more educational opportunities in the future. Now I would like to introduce you to our speaker for this evening. Tonight, you will hear from Dr. Mehmi, a medical oncologist at the Angeles Clinic and Research Institute, a Cedars-Sinai affiliate in Los Angeles, California. Dr. Mehmi specializes in melanoma and non-melanoma skin cancers and brings over a decade of experience in patient care. In addition to his clinical work, Dr. Mehmi is actively involved in research aimed at advancing immunotherapy and targeted therapies in the field. His work includes exploring novel combination approaches to enhance treatment responses and reduce toxicity associated with current immunologic agents. So now I will turn it over to Dr. Mehmi to share his slides and his presentation with us this evening about ASCO 2025. Thanks, Dr. Mehmi. Thanks for being here.
Thank you. Can you guys see my slides and can you hear me well?
Yes, if you could make it full screen, that would be great. There you go.
All right, fantastic. Hey, thank you, Miriam. Thank you, MRF and KROM for inviting me to talk about this important topic. Usually when we come back from ASCO, American Society of Clinical Oncology annual meeting, there's so much exciting stuff going on. It kind of reinvigorates all the oncologists to work harder, get more done, and figure out new ways of tackling the problem of melanoma, and particularly uveal melanoma, which is a topic of conversation. In addition to talking about the clinical trials that were presented at ASCO 2025, I wanted to start off with a little bit of background on this topic. So we'll cover some epidemiological data, some prognosis and staging data. What are some of the options in early stage disease or even in preoperative or pretreatment disease space. And then we'll cover postoperative, trying to reduce the risk of recurrence space, and then also systemic diseases. And there we'll talk about a number of new clinical trials that are available in this space to help our patients. So as you know, uveal melanoma is melanoma of the ocular space. There are a number of 3 different compartments where it could develop, so we won't spend too much time on it. As you know, that it's not a very common melanoma, but it's the most common primary cancer of the eye in adult patients. It represents about 5% of all melanoma and roughly makes up about 2,000 cases per year and 8,000 globally. The risk factors are different than cutaneous melanoma, and they're listed here. Some of the germline mutations, such as BAP1, NF1 gene mutation, having dysplastic nevus syndrome, they are sort of predisposing factors for all patients. Unfortunately, 50% of the patients who have had their disease treated in the eye will go on to develop metastatic disease, unfortunately, and a lot of this disease is predominantly in the liver. We haven't had greatest of therapies in metastatic setting, and because of that, our survivals are fairly dismal, but every day things are getting better. So we are looking at a new therapeutic options that are becoming available. So whenever we talk about any malignancy, in a sense, especially in solid tumors, we always want to stage, and that stage isn't just for simple information, but that allows us to sort of prognosticate the future. What's the likelihood of this disease coming back in 1 year, 3 years, 5 years, and so on and so forth. And also, depending on the size of the tumor, that stage could let us know, what's the primary treatment or initial treatment of that tumor is going to be. And, in the past, we looked at the tumor size, and if the melanoma was only present in the eye versus other places, that helped us determine what the initial stage is, and based on that we could prognosticate what's the likelihood of the disease coming back in the next 3 years, 5 years, and so on and so forth. Then we learned that some of these uveal melanoma had certain genetic changes that made them sort of higher risk of recurrences and not recurrences, so we started to add that information. And now we're looking at gene expression profile. So every tumor that develops or every melanoma, uveal melanoma that develops in the eye, we can take a piece of it and look at its genetic signature. And based on that genetic signature, these tumors can be classified into class 1, class 2, class 1 prime positive, other markers that can help us further prognosticate about future recurrences. And that's even more important nowadays, and I'll go over that. So, obviously you can see that the class 1 tumors they tend to be smaller, they tend to have less, sort of some serious genetic mutations, and that helps them do well over in the long run. Whereas class 2 tumors are higher risk, their risk of recurrences are high. So, and the patients develop metastases sooner. This is again, when you add on a gene called PRAME onto these classifications, that further breaks them down into, high risk, low risk categories. So now based on the genetic data versus tumor size alone, with genetic data, we can much easily prognosticate these patients and pick out the ones that have much higher risk of recurrences and perhaps offer them treatment, to reduce risk of recurrences. And we'll talk about that soon. In the past, it's been very challenging for developing treatments to reduce recurrences, which are called adjuvant therapies for uveal melanoma. And essentially, these therapies are that once an individual's ocular melanoma has been treated with radiation, typically that's the course, the plaque therapy. At the plaque therapy time, we also do a biopsy of it and classify that particular uveal melanoma into class 1, class 2, and stratified it further. And then based on their, classes, you can offer them treatments to reduce risk of recurrences. So that's the adjuvant therapy. But in the past, it's been challenging to do adjuvant therapies because we know that the uveal melanoma is rare, and it was difficult for us to enrich the high-risk group. When you want to establish a therapy, giving it to everybody who comes through the door makes it difficult because there's risk associated with the treatment. And if you're giving treatment to people who don't have high risk of recurrences, then one, you're thinning the pool. Also, you're exposing individuals who may not recur with the uveal melanoma into the liver or other spaces. You're exposing them to toxicity issues that come up with these treatments. And then we didn't have good treatments in the past, even for stage 4 disease, let alone for early disease. So that made it difficult to develop adjuvant therapies or post primary therapy of uveal melanoma. And this is a list of all the different trials with a very small amount of benefit. Of all these, I think I've seen sunitinib, one of the small molecule tyrosine kinase inhibitor, used quite a bit. Most of it was studied at Thomas Jefferson, and shown that in high-risk individuals, if we're using that treatment, then we can reduce the risk of recurrences. And some of the other therapies have very small benefit, but due to the high risk of toxicity, they weren't really mainstream treatments. This was the trial that was presented actually last year by one of my friend Suthi Rapsivan from Georgetown, looking at adjuvant therapy for uveal melanoma. Essentially, they took the individuals had uveal melanoma, either they were class 2 by genetic gene expression profiling, or the basal diameter of the tumor was greater or equal to 12 millimeter, and these patients were treated with nivolumab and ipilimumab for 48 weeks based on the dosing that's showed there. And the primary endpoint of the study was 3 years distant metastatic free survival, meaning are you able to prevent metastases from developing or at least delay them? And the secondary endpoint was median DMFS and overall survival, and what are the toxicity of these drugs. And this was compared to not a control group in real time, but a synthetic control group from a large database. And when the comparison was done, after a follow-up of 36 months of these patients that were treated, it showed the benefit that, the primary endpoint of 3 years DMFS survival versus the control group. And that benefit was more than good enough that this study is being studied in a randomized fashion, and this trial should be coming up in the next year to two. I'm very hopeful for this. Okay. And additionally, the other two trials that I'm actually highlighting here, these are not from the ASCO meeting this year, but these are the two trials that are already enrolling at a couple of sites, and we're opening it here at the Angeles Clinic in the next month or so. And these two trials are also adjuvant studies, meaning after the patients have received their initial primary treatment to the eye tumor or uveal melanoma tumor in the eye, and then they are risk stratified, and based on the high risk group, they'll be taken through this adjuvant clinical trial therapy. And the first one is adjuvant cozinostat in high risk uveal melanoma with NCT number 06932757 for your reference if you want to look it up. And the rationale is that the BAP1 mutation that's present in about 80% of uveal melanoma, it leads to number of other genes that makes that tumor more likely to spread. And then this drug, cozinostat, inhibits that one of the component that downregulates those metastatic driving genes. We'll leave it at there. So, but the initial data has shown that this drug is functional in doing so. And so they'll be looking at class 2 gene expression profiled tumors in patients, and also the individuals who have greater than 12 millimeter of basal diameter in the eye. And the treatment is with the drug cozinostat. It will be given 12 milligram in a capsule form, taken orally about 3 times a week on a 21-day cycle, and total of a year of treatment again. And the goal of this study will be to look at how good is it in preventing distance metastases. Additionally, they'll be looking at progression-free survival, overall survival, site of first recurrence, and toxicity of the drug itself. The second drug trial is based on already well-established activity of Kimmtrak or tebentafusp in stage 4 disease. As you know, it's been approved for a couple of years now in HLA-A*02:01 positive patients. So this study is, has a good rationale stating that if you can treat the disease in stage 4, can we move it earlier and trying to prevent that stage 4 development? This trial is called ATOM, ATOM, because it's established role in metastatic disease with overall survival advantage. Again, this particular clinical trial will be looking at larger tumor that have, stage 3 because of their basal diameter is large, or gene expression profile class 2 or higher, and if they happen to have another genetic marker called monosomy 3. Again, these patients will have to be HLA-A*02:01 positive, so about 30 to 40% of all, roughly speaking, of all melanoma comers. And here the treatment period is only about 6 months, and with the primary endpoint of relapse-free survival, secondary endpoint being overall survival, toxicity of the drug, and quality of life events. So we're pretty excited for these 3 trials in adjuvant space, attempting to decreasing the number of individuals that can go on to develop advanced disease. This is a bit of a new topic in uveal melanoma, but it's well known in cutaneous melanoma, where we give treatments prior to either the melanoma tumor is taken out, or it's with surgery, or for example in ocular melanoma or uveal melanoma, these prior to start of radiation, that you're giving these treatments to see, one, if you can shrink the eye tumor, and also can you, by shrinking that tumor, can you also have an impact on the body later on that it reduces the risk of development of systemic disease. So as you know that darovasertib is currently being studied in stage 4 ocular melanoma, but part of that group had intact eye tumor as well. And because that tumor shrank down, based on that, they've started to give patients with large enough tumor few doses of darovasertib to see if you can decrease the size of the tumor, keep the vision safe, protect the eye, and also perhaps later on reducing the risk of metastases development. Okay, this trial is ongoing and we'll look for its results down the road. This trial is Compass trial by Aura Bioscience, and again, this is you know, trying to treat the tumor, the primary tumor in the eye itself, with a drug called Belsar AU011, and trying to see if when we give this AU011 viral-like particle, it can deliver the toxic agents to the melanoma cells and then release these particulates off the tumor that can be recognized by our immune system, hoping to not only decrease the size of the eye tumor, but also allowing our immune system to learn what this uveal melanoma looks like so it can protect the patient down the road from metastases development. Again, this is an ongoing trial and we'll look for its results soon. So once somebody develops metastatic disease, we talked about that about 50% of the uveal melanoma patients will go on to develop metastatic disease, and most of the time that tends to be in the liver, up to about 80% in combination with lung and other sites. When patients have liver disease only, it makes perfect sense to treat the tumor within the liver itself. That helps in a number of ways. One, you're treating the tumor. Two, you're not exposing the entire human body to these drugs and leading to increased side effects. So there are a number of different hepatic directed or liver directed therapies that are available, either in embolization form or, and those embolizations can be chemo, immuno, radioembolization, resection, different forms of ablation of those tumors using radiation or radio frequency ablations, proton therapy, and isolated liver perfusions, and we'll talk a little bit more about that. So these are all different forms of liver-directed therapy. And when we consider these patients for liver-directed therapy, it's a very individualized approach, and a lot of time we'll take into account, how much of the liver is involved, what's the trajectory of the tumor growth that would help us, figure out what's the most appropriate therapy for these patients. So this is the first poster from ASCO that I will highlight for uveal melanoma from Dr. Cedar over at Thomas Jefferson University. And this particular poster was about a trial that looked at uveal melanoma patients with metastases to the liver. Less than 50% of the liver was involved with tumor, and the treatment was with two drugs called granulocyte macrophage colony stimulating factor, or GM-CSF, which is naturally produced in the body to help our bone marrow grow these macrophages, and then interleukin-2, which is a well-known small molecule that's produced in our body, but it's been used for melanoma treatment for a long time. And when we used, or at least when the team at Thomas Jefferson used this treatment, not only they were looking to treat the tumor itself with embolization, but they were also looking to boost the immune cells response or ability to learn about this tumor so it can sort of learn how to prevent any future metastases from occurring. Here you look at some of the survival curves when you're comparing it to Kimtrac or Hepzato, and based on this immunoembolization, you can get fairly close results to some of the other systemic therapies that are available. So here we talk about the percutaneous hepatic perfusion, PHP or Hepzato, that's now FDA approved for patients with metastatic uveal melanoma. It was compared to investigator's choice and shown benefit, and this data has been updated. And we've been treating our uveal melanoma patients with this particular approach as well, most often very easy to tolerate therapy. There is a period of about a week to 2 weeks where patients feel fatigued, some degree of nausea, vomiting, low blood cell count, because this is a chemotherapy that the patients get exposed to. But most of those issues do tend to improve after about a week to 2 weeks. And like I said, it's an ongoing treatment options that's available, and now it's being studied in combination with other options, and one of those options we'll talk about down the slide deck. So, as you know, that in cutaneous melanoma, there's a sort of, breakdown of melanoma in two different spaces. Is it BRAF mutated or not? And we don't have that kind of breakdown in uveal melanoma, even though we know that about 80 to 90% of the patients with uveal melanoma, that uveal melanoma will have genetic alterations, particularly in GNA11 or GNAQ gene. For a longest time, we've tried to play with this point to see if we can block that ongoing signal to improve the disease. A lot of the time we use drugs that were already available, like sorafenib, sunitinib, trametinib, but the results were very mixed. Response rates weren't all that great, the responses didn't last all that long, and the toxicity still held. So, it's not the most common of treatments we saw at that time. But since the development of the PKC, or protein kinase C inhibitor, darovasertib from IDEAYA, meaning the targeted therapy component for uveal melanomas looked very promising. And this is an ongoing phase 3 study. This is the data on phase 2 trial, looking at darovasertib in combination with crizotinib, and comparing it to standard of care therapies available, such as immunotherapies, and see, how we can benefit our patients. The patients, the early phase data show that up to about 50% response rate in untreated patient, and about 30% response rate in patients who have received other therapies in the past. So again, this is an ongoing trial. I urge our patient advocates, our patients and other providers to consider patients for this trial, so we can get to the end of the trial, show the benefit, and hopefully get the drug approval. So this is the second highlight from ASCO 2025 for uveal melanoma, in my opinion, of a drug called DYP688. It's an antibody drug conjugate. An antibody drug conjugate is, think of an antibody with two binding end, or two prongs, where one side has a binding portion on the melanoma, the other side has a payload that's being delivered to the cancer cells. There are a number of ADCs, or antibody drug conjugates, that are already approved in other cancers. So this is the first in human study of DYP688 that's delivering a direct inhibitor of GNA11, GNAQ protein in metastatic uveal melanoma. So here's what I was talking about. This is, so one end, it has this SDZ475. It's a potent selective inhibitor of this GNA11 Q enzyme, and then the way it delivers this inhibitor is by binding to a molecule already present on uveal melanoma cells called GP100. My best analogy for this is that if there are 100 people living in one building and you want to send a letter to them, how do you send that letter to that one person? You write the address of the city, the zip code, the street, the house number, and then amongst that house number or apartment building, you put the name of that person. So this is one way of showing that I want to deliver a toxic drug that is directed at a mutation, but that's not good enough. I also want it to go into that one cell or number of cells or group of cells or a tumor where that mutation resides. So the GNA11Q is the mutation, and SDZ475 is the drug, and we're going to use PMEL17 or GP100 on the surface of the melanoma cells as a target. So the antibody goes and binds to GP100 and then delivers that potent toxic agent that inhibits the GNAQ, GNA11 mutation and prevents or stops the cell growth or the cancer cell growth. So this drug's been studied in a number of patients, showed that it was very, very tolerable. If you look at this color scheme here, the maximum toxicity grade, lighter blue shade is low grade toxicity. The darker blue shade is sort of the intermediate, and yellow or orange is the grade 3 toxicity or higher. And most of these bars at number of different doses are blue. So meaning that 66 patients that were treated with this agent showed very tolerable side effect profile, most of them early grade. The panel here on the lower left shows you that there is good amount of activity in this waterfall plot, where they saw stable disease, partial responses on different schedule levels, either every Q2 weekly or Q weekly, okay? And here is the swimmer's plot showing not only we want responses, we also want responses that last long. So here, the longer the line or the bar here shows you how long that response is lasting for the patients. So very promising antibody drug conjugate coming through the pike for metastatic uveal melanoma, because most of the uveal melanoma has this GNAQ, GNA11 mutation. So that sort of wraps up the targeted therapy portion, and now let's move on to the tumor immunity portion of uveal melanoma. We already know that there's only about small group of uveal melanoma that are sensitive to immunotherapies, okay? And that was shown by 2 different trials about 2-3 years ago by Dr. Patel's group at MD Anderson with ipilimumab, nivolumab, showing response rates of about 18% in metastatic uveal melanoma that was previously haven't been treated. Some of these responses were durable, and we also didn't see any additional toxicity than what we've seen in cutaneous melanoma. The second trial took place in Spain, also showed similar results. So for some of the patients that come through the door, we do consider ipi-nivo for their treatment. Here's the first combination trial last highlighted in ASCO 2022, so a couple of years old. But the reason I'm highlighting it is that I think it's one of the exciting trials that showed very good results, and at least in the initial 7 patients treated and included in this analysis. This is a combination of ipilimumab and nivolumab with Hepzato, or liver chemosaturation with Hapsaro. What I'm really excited about here is that they had one complete response and 5 partial responses and 1 stable disease that showed an 85.7% overall response rate. And this was established at median follow-up of 20.2 months. And out of that, 4 patients had an ongoing response. The hypothesis is that liver environment is very immune suppressing, you know. So if we're able to treat the liver tumors with Hapsaro or chemotherapy in this particular situation, that allows the immune therapy to work better. So again, I understand that this is only 7-patient data. We need much larger data to reliably say that this is an applicable therapeutic option for our patient, but it is very exciting data, and I look forward to its larger cohort set to be presented later on. We can't go further without talking about tebentafusp, the only FDA-approved systemic therapy for metastatic uveal melanoma with overall survival advantage. This was approved back in 2022. This is the key publication data from New England Journal of Medicine back in 2021 that showed overall survival advantage when patients were treated with tebentafusp versus control arm. And this data since has been updated, showing ongoing benefit. And toxicity is fairly predictable, and most of the toxic events tend to happen within the first 3 weeks when patients are being dose escalated. And even then, we've had more than enough experience to predict the toxicity and treat those patients. Again, this slide's a bit older, but I wanted to highlight combination approach or even single drug approach with IMC F106C, which is now called brenetafusp, which is sort of a related bispecific antibody to Kimmtrak or tebentafusp. But this particular bispecific antibody targets PRAME rather than GP100 on Kimmtrak. And here, tebentafusp naive patient of uveal melanoma were treated with brenetafusp and showing partial response, and some of these partial response are ongoing. So my hope was that at some point Immunocore would expand this cohort, so we continue to talk to them for that opportunity. So this is the Replimune study of RP2 in combination with nivolumab that's ongoing, based on small group data that was included in their initial study of 17 patients that showed objective response rate of 29.4% and the disease control rate of 58.8%. Keep in mind that these patients have had received prior therapies. So very good and exciting data of small group of patients. And based on this, a randomized phase 2/3 clinical trial is ongoing. This is trials in progress from ASCO 2025 with the trial design and inclusion-exclusion criteria. I dearly hope that this trial continues to proceed regardless of what happened with RP1 today. So the next clinical trial that I'd like to highlight was, again, a trial in progress by Dr. Nathan, looking at a small molecule inhibitor of one of the signaling molecules in sort of suppressive immune cells, and this molecule is called PI3 kinase delta. And when you control this particular molecule, you are putting on, it's a double negative, brakes on the brakes of immune system. So by taking away the brakes, you're essentially accelerating the immune system, so hoping to increase immune activity towards uveal melanoma that will allow you to control it. This, again, trial is ongoing and we'll look for its results in the next couple of years. The inclusion-exclusion criteria are quite generous, and I'm happy about that because in uveal melanoma, making clinical trial restrictive does not help our patient population. The next question I always get from my patients who come into the clinic is, what about T-cell therapy? That's all the fuss in melanoma and other places. What about in uveal melanoma? Well, we're not behind in that sense. There's been studies reported for TILs in metastatic uveal melanoma. Unfortunately, the results aren't as good as what we'd like to be. And the study is still developing. I'm aware of University of Pittsburgh Medical Center currently with the clinical trials with for uveal melanoma with the TIL therapy. So I'm sure the resources are available to look into that trials for all patients through MRF and QRM. I think I'm going to stop there and we'll answer any questions.
Fantastic. Thank you, Dr. Mehmi, for that comprehensive overview. I do have a few questions for you, and we can get right into it. But thank you for walking us through, spotlight both of us, for walking us through everything related to uveal melanoma, and especially some new treatment advances and clinical trials. So we have a question in the chat asking, how do you know if you have a certain mutation? The only information that they got was class 2 PRAME positive, but they didn't know anything about a breakdown of genes or genetics. So can you share a little bit about what that process looks like for patients?
Right. So, there are two key mutations that we rely on in uveal melanoma. One is BAP1, so about 80% of the patients will have that gene mutated. So it's assumed that most of the patients will have that. And then the other mutation, GNAQ and GNA11, again, 95% of the patients will have that mutation. So I think so testing for those mutations doesn't make sense. If it were a rare mutation, then that's something you can definitely look at. It is typical for our practice to sequence every tumor, uveal melanoma or not. So when somebody comes in with metastatic, disease, and obviously in my context it's melanoma, I will biopsy, or previously biopsy tissue will be sent to one of the, next gen sequencing companies. There are a number of them, Tempus, Caris, Guardant, any of those. And that analysis will help us in determining if there are any additional mutations that we can leverage for trial purposes.
Speaking of trials, we got a question in the chat, and you might get this question often, but can you guarantee that you're going to get the actual drug versus being in a randomized trial? And how can patients know what they'll get?
So, one of the things I always talk about to my patients is that when it's an early phase study, phase 1 or phase 2, most of the early phase study tends to be single arm studies, meaning whatever drug is being studied is the drug that the patient is getting. They are never placebo controlled trials. If there is, sometimes, we will have trials that are comparing best supportive care to a drug. But in uveal melanoma space, we don't have that. because there aren't that many options available. So most of the time you'll have a trial that's comparing immunotherapy to target therapy, i.e. IDEA 196 study that's looking at darovasertib and crizotinib comparing to immunotherapy. And then same thing with Kimtrack when it was studied not against placebo, it was against pembrolizumab or chemotherapy or ipilimumab, nivolumab. And then RP2 is also being studied against standard of care for the HLA negative patients. So there, you may not get the research drug, but the comparative arm has to give you something. So I'm not aware of any clinical trials in uveal melanoma space that are placebo controlled at this point, or at least meaningful trials that are placebo controlled.
And that trial, the IDE 196, is that one a randomized trial or single arm?
Correct. It is a phase 3 randomized study looking at IDE 196, which is the darovasertib with crizotinib against standard of care of ipilimumab, nivolumab, or some of the other medications that are already shown benefit. Now, how good that benefit is, that's debatable, but they've shown some benefit.
And the patient, of course, doesn't get to choose.
Patient does
Which
not get to choose in
they
a
get.
randomized study. And also the physician or the trial conducting team doesn't have any control over, what
It's good
patient
to know.
randomized to.
Yeah, that's really good to know. So there was a question about where to find trials. So like if they want to get involved in a specific trial, like one you mentioned, how would a patient find it or where it's being administered?
So I don't favor the clinicaltrials.gov website as much, even though it lists all the trials. Unfortunately, that site doesn't get updated as often as I'd like to have it. But I've included my email address, so shoot me an email. Websites from Thomas Jefferson, UCLA, Cedars-Sinai, Memorial Sloan Kettering, MD Anderson, University of Colorado, George Washington. All those, those academic sites are good sites because they will list their clinical trials and in the uveal melanoma space. And I'm sure, MRF does a great job about, connecting people to different clinical trial options.
Exactly. Yeah. So we do have a clinical trials finder. So you can put your information, and it's a little bit better than the clinicaltrials.gov because it'll really help explain the information to the patients, help match them. And we have a navigator that can help navigate you through the process. So let us know if you want more information about the trial finder. Okay, so we got another question here for you. How is DYP 688 administered?
I believe it's an IV formulation, given either every weekly or every 2 weekly.
Okay, great. I know that was a pretty specific question. So I have this other question that a patient sent in before the webinar tonight. And if the patients are looking to learn more about genetic testing for long-term survival, what would you share with them?
So I think that's a great question. So that it's a bit two-part, so if we're looking at early stage disease where the patient is going through treatment of their eye tumor, and most of the ocular oncologists, when they're doing the plaque therapy, they'll also biopsy that tumor and send it for classification or genetic or gene expression profiling to risk stratify into class 1, 1A, class 2A, 2B, and so forth. That helps us, prognosticate, what are the likelihood they're going to have metastatic disease down the road. And based on that, they could potentially be eligible for some of the clinical trials to reduce the risk of recurrences. So that's part one. Part two is, genetic information that could help us determining how a patient is doing while they have metastatic disease, right? So data from tebentafusp clinical trial showed that, prior to start of treatment of metastatic uveal melanoma, you can check the circulating tumor DNA. And with treatment, you expect or you hope that that circulating tumor DNA is decreasing. The more it decreases, better the benefit. And as long as you can, keep that circulating tumor DNA down with treatment, you're expecting the patients to do well. So I guess there's a third portion that, that it's not fully sort of out in the public yet, but the data is still developing about determining when patients gonna recur. While say that somebody's had their ocular tumor treated, and then you can look for the same kind of genetic markers in the blood as their tumor's genetic marker. And when you start to detect that genetic marker, that could potentially give you hints on recurrences. In Merkel cell cancer, if you began to detect that circulating tumor DNA, there's roughly about 3-month period before you start to see the disease on CT scans or MRIs. So it could give you an early warning, but so far, none of the diseases is being treated based on just because somebody has a circulating tumor DNA positive for a disease. Complicated answer, but very important one.
Absolutely. So I think we have a final question here for you, and then we will wrap up. Are there any trials going on now for presumptive liver mets for high-risk patients? So they don't have tissue proof, but potential liver mets for high-risk patients.
Right. So if they don't have any evidence of disease on the scans, but their eye tumors already treated, then if the time is more than a year, then it's difficult to put them on a drug for sort of reducing the risk of recurrences. But the 3 trials we talked about, one with Cuzinostat, another with Kimtrac, and the third with Opdivo and Yervoy, that's essentially the role that these, if that patient's been determined to be high risk for recurrence, they can enroll onto that trial, and a couple of those trials will allow even 6 months of time in between their eye tumor treatment to the time the sort of presumptive metastatic disease to the liver treatment is started. So it's pretty generous. Most of the time, the start of preventative therapy is about 3 months, but for ocular melanoma, we're making it a little more longer time period just so we can complete these trials.
That's fantastic. That's great. All right, well, those were all of the questions that we have time for today. It looks like a lot of great questions coming in, so please do send us an email at cureom@melanoma.org for more information. We'll get those questions over to Dr. Mehmi. So I'd like to thank him, Dr. Mehmi, for sharing your time, your expertise, and insights during tonight's Ask the Expert review of clinical trials and ASCO 2025 in uveal melanoma. We appreciate all that you do for the melanoma community, and especially tonight for taking some extra time out of your day to be here with us.
No, thank you for letting me be here. Hopefully we imparted some information that'll be useful to a lot.
Absolutely. And actually, this will be recorded. This is recorded, and it will be on our YouTube channel in just a few days. So you can check this out again or watch at a later time. So thanks everyone for being here. And please do fill out the survey that will pop up on your screen. And feel free to email us with any questions. Again, visit melanoma.org for more information. And thank you everyone for being here. Thanks, Dr. Mehmi.
Hey, have a good night. Thank you.
Take care.